Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work, and sometimes stumble, through real-life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri.
And I'm Andrew Sanchez.
And we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
All right. Welcome back, everybody. I say back because Mike and I haven't hit the record button in about 2 months. Thanks for sticking around with us and being on our little Diagnostic Atypia holiday. Who do we got here today, Mike?
Well, we got myself, and then we've got Alec, a guest who's going to be joining us and has a case for us, I believe. We're super thrilled. I just met him now, and excited to now think about a case together.
Yeah, Alec is a longtime friend of the CP Solvers, member of the CP Solvers, actually. So I see him there all the time. And before the Academy was a thing, we interfaced a lot on Twitter and just in Morning Report. So we've been good friends for a while. But Alec, thanks for bringing us a case. And what have you been up to this week?
Yeah, thanks so much, Mike and Andrew. I'm super excited to be on Diagnostic Atypia. Love it and love what you guys are doing. And yeah, I'm on service right now. This is the week 2 of service, and things have been super busy at the hospital. A lot of interesting cases, a lot of good learning. So yeah, just sort of keeping up with that.
Oh, awesome. Well, great to have you, and very excited to see what you brought to us. Let's do it.
All right. So I guess just for preface, I have 9 aliquots, so it's a little bit of a longer case, but hopefully the journey will go smoothly, and then we can sort of take things from there.
Sounds good.
First aliquot for you. This is a 35-year-old gentleman and presenting with cough and dyspnea. And just for context, I was admitting on nights when I encountered this patient. So he tells me he was feeling well when 3 weeks ago he began having B symptoms like night sweats, fevers, and chills. He thought he had a virus with a sore throat, some rhinorrhea, myalgias, a little bit of a dry cough. And although the pharyngitis, the rhinorrhea, and the myalgias got better with some time and some over-the-counter agents he took, the cough sort of persisted, and he gradually developed some dyspnea on exertion, some orthopnea, and some pleuritic chest pain. And for that reason, he decided to come into the hospital. So he knows the cough is worse when lying flat. And then he's also had one episode of post-tussive emesis that was non-bloody, non-bilious. He's had a mild headache as well, just in the back of his head. No photophobia, no visual changes, no neck pain, no GI or GU symptoms. He can swallow fine, no weight loss, no rashes, no belly pain. And otherwise, he's been doing okay. He's never had anything like this before. He's usually very active, goes to the gym regularly. He's still been working, but he's just noticed that he's been a little bit more tired and dyspneic on exertion during that time, particularly going up the stairs. And that's where I'll leave you for aliquot on.
All right, Andrew, you want to go first?
Yeah, I can take this one. This is a really interesting and very fast start because clearly this is a young guy who's not doing well. I just turned 30 and I haven't had any symptoms like this. I'm a pretty healthy guy. I'd be pretty worried if I had these symptoms for 3 weeks. I think probably what's on everyone's mind is pneumonia when they hear a lot of the symptoms that Alec just listed off. Someone coming in with a acute to subacute inflammatory syndrome, lower respiratory tract localization, cough, and then shortness of breath. Shortness of breath can be driven by a couple of different things. Hypoxemia in itself is kind of the most morbid thing to consider, and that's what kind of makes us wake up and think really hard about what's causing that problem. But I've seen patients also when they come in with a very pleuritic syndrome, like they lie flat and they cough, which is what Alec actually told us. If that leads to very strong coughing fits, the patient may not actually have frank hypoxemia, but it's uncontrollable coughing where they just can't catch their breath from that very acute kind of paroxysmal event that prevents them from being able to catch their breath. So I think something that we'll get soon and free is the vitals to tell us, is this someone who's hypoxemic? If I had to put my money on it, it's hard to say actually if they'll actually have frank hypoxemia, because if they're walking around just like they're lying flat and they're coughing a lot, again, their saturations may be completely fine, and it's just a pain phenomenon that's going on inside of the thoracic cavity. But they also may very well, just by virtue of this being an exertional thing, they may very well have hypoxemia, and we have to solve that problem. But I think the last thing I think of when I'm starting to think of pneumonia is kind of the natural history. I think that's a really key factor when thinking through the problem of, does this patient have pneumonia when they have an acute inflammatory illness, lower respiratory tract localization? How do they do with antibiotics? Did this patient go to a clinic and get empiric treatment and they failed that treatment? Because then makes you think of non-infectious causes of lower respiratory tract disease, or you're not treating the correct disease for pneumonia. So these are just some like early thoughts. I'm curious, like, has he engaged with the healthcare system before this and failed antibiotics? Where does that take us? But off the bat, I would say that the subacute tempo of this is it's not chronic, but it's not very acute. Like a typical pneumonia story is like a couple days, you kind of get hit by a train, you get sick pretty quickly. But so this has been going on a little bit longer than that, which already makes me feel a little bit funny about what could be going on in terms of a true typical bacterial pneumonia. But there's just some shotgun thoughts. Mike, do you have anything else to add?
I think the only thing is, if you have someone, really anyone who's young and has a pretty severe infection, and anyone who has more of like a subacute infection, especially pulmonary wise, it does always like raise the question of immunocompromised status, right? Like that if you think about the things that cause pneumonia in people with AIDS, right? They oftentimes are more insidious or have sort of slower onset. And additionally, there's some people argue any person in their 30s who gets hospitalized with pneumonia should probably at least have an HIV test. I mean, all adults should, but right, because like most 30-year-olds, like you said, Andrew, really don't actually they're able to sort of deal with infections pretty well and don't end up getting hospitalized or having significant lingering symptoms. So I think his immune status, would be the other thing I would just may change management or change the way what tests I would order.
All right, Alec, what do you have next?
Okay, excellent thoughts to start, guys. So just a little bit of background for this gentleman. He's got no past medical history, no surgeries. As far as medications, he was just taking some over-the-counter cold and flu stuff. He's got no family history, no history of infections, autoimmune disease, cancer, really nothing. In regards to his social history, he hasn't traveled recently, but he went to Mexico about 3 years ago. He goes to northern New Mexico a couple times a year, but otherwise stays in Texas. He's got no known TB exposures. He works as a bartender. He could have been around some sick people, but he's not really sure. Over the last 4 or 5 months, he had been drinking maybe 6 to 7 alcoholic drinks per day. No history of withdrawal. He smokes about 4 or 5 joints of marijuana a day, but his source / dealer has been unchanged during this time. No history of substance use. He's sexually active with one female partner, but not using contraception, and no history of STIs. And just for clarification, I have modified these details for patient privacy purposes. But I'll stop here and get your thoughts before giving you some more objective information.
I feel like there's a lot of things there that are either clues or red herrings, right? Like it's the board exam where the geographic location is always listed, right? And then and then the fact that it's interesting that you mentioned sort of like, is there a new dealer for the marijuana? Just like another thought, right? What else could be in there? And then I guess, to be fair, going back to my previous question, I mean, we do know that those who, you said he was drinking 6 to 7 drinks a day. Is that right? Yeah. So, I mean, that sort of creates a relatively immunocompromised status as well. So I don't know that it I don't know. It doesn't sort of change what I was thinking before, but it helps explain maybe why this 30-year-old has he has some risk factors to maybe not do as well with infections that another 30-year-old without those risk factors may clear just fine.
Yeah, great thoughts, Mike. Yeah, I'm very struck. When was the exposure to, you said northern New Mexico? When was that about, Alec? Or is that that's where he's from? And I'm just wondering the time point that he was there.
Yeah, he lives and work around Houston. That's where I practice. And then he travels a couple times a year to northern New Mexico just to either engage in outdoor activities or whatnot. I think the last time he had gone was probably a few months before presentation.
Got it. Okay. Yeah, I'm asking because in that geographic region, there's the endemic mycosis cocci, but I want to say that the patient, if this was, a little bit ago, the distance time from that exposure is a bit too long for him to have this onset of pulmonary symptoms, because usually you have this inhalation of that fungus during like dust storms, or if you're just out like doing a lot of heavy breathing activity, running, cycling. Usually within that week, I believe, you start to develop those pneumonia type symptoms. So, yeah, I think, very interesting risk factors, but I want to see what's going on in his chest, especially given how pleuritic it is with the orthopnea and the dyspnea on exertion. I'm very excited to hear the vital signs. But I think an important point to bring up here is if his chest x-ray is very unimpressive, our pretest probability here for some sort of parenchymal or pleural process leading to these symptoms is pretty high, just based off of the description. I say that because of the pleuritic component, like he lies flat and he has the cough and he has the dyspnea on exertion. You can have very subtle chest x-ray findings, or even missed chest x-ray findings given the just the test characteristics of chest x-ray aren't. It's not the most sensitive test in the world. So if we really want to convince ourselves there's nothing in the lungs driving these symptoms, we really need a CT chest in this patient. So it'd be reasonable to even just go straight for that, just to further characterize what we're seeing in terms of, does he have anything that looks like pneumonia? And I guess, Mike, what's your practice in using IV contrast up front in a CT chest for a patient like this? Do you ever do that, or do you usually wait and just see what the CT chest without contrast looks like first, if you're going to go for it?
I feel like I will just go for the contrast if I have a very high suspicion that pulmonary embolism is going to be at least equally likely to a parenchymal disease, because giving the IV contrast, when you're just looking at the parenchyma, it can make things light up and things can look maybe like a faint GGO when it's, really not. It kind of can overcall things sometimes, the contrast, if you're looking at just the parenchyma itself. So I feel like it's when you're at least equally likely the PE. I feel like that's when I go right for it. And in this guy, I don't know if that's equally likely to the other things I'm thinking of, parenchymal diseases. So I don't know that I would go to that.
Got it. Yeah, I find I usually reach for the contrast more so than not, if the story at all is consistent with PE. And I think any sort of pleuritic syndrome, kind of like what we're seeing here, it could be the case. I usually go for it just because there's literally no other way to know without that contrast. I also use it to look for like complications of pneumonia too. Alec, I'm curious what you all did. What did you all do next?
Awesome. Yeah. So I'll give you the exam. So he was afebrile. Temperature was 98.2. His blood pressure was 126/72. Heart rate was 120. His respiratory rate was 22. And he was saturating 98% on room air. His BMI was 24. So when I saw him, he was sitting in a chair. He wasn't in any distress. His oropharynx was clear, no erythema. He had no thyromegaly, no lymphadenopathy in his cervical chain. On a cardiac exam, he was tachycardic but regular, no murmurs, no rubs, no gallops, couldn't appreciate any JVD. In regards to his lung exam, normal effort, no accessory muscle use, no wheezing or rales. He had some decreased breath sounds on the left from basically the mid-lung down. And his abdominal exam was benign, no organomegaly. He had no lower extremity edema. And his neurologic exam, he was fully oriented. Strength was symmetric. Sensation was some tactile light touch throughout. He had no tremors, no nystagmus, normal gait, Normal cerebellar testing was completely normal. And then no rashes on skin exam. And then for initial labs, he had a white blood cell count of 15.7, was neutrophil predominant on the differential. His hemoglobin was 10.7, and with an MCV of 100, and his platelets were 603. In regards to his CMP, his sodium was 132, potassium was 4.7, chloride of 95, his CO2 was 27, BUN was 8, creatinine was 0.6, glucose was 100, calcium was 9.8. His AST and ALT were both normal. His total protein was 7.3. His albumin was 3.6. Bilirubin was normal. And the alkaline phosphatase was 227, with the upper limit of normal being 104 for our lab. His EKG showed sinus tachycardia. His troponin was negative. His BNP was normal. COVID flu RSV screening was negative. And he had a urinalysis without proteinuria, hematuria, or pyuria. And then let me show you the chest x-ray.
Ooh,
and then I can let you guys take a look at that. And that will be the end of this aliquot if you want to describe it, or I can give you the radiology read.
Whoa, what is that, Mike?
well, that's going to be the cover for our next episode. Yeah. So, how do you want to do this, Andrew?
Yeah, all you. I feel like you're the palm guy, since you almost wanted a palm grid. So all you, my friend.
So I feel like I guess it's reading a chest X-ray on an audio podcast. I'll do my best here, but I feel like what I teach so far is that like you should give your first impression and then kind of go systematically. So my first impression is that you have a pretty obvious left-sided effusion, looks like a relatively large heart. And then probably most importantly, you've got sort of these just like opacities throughout both lung fields, sort of more like nodular. And yeah, I would say that they're not really respecting any one side or even maybe a little bit more predominant in the lower lungs, but hard to say on a chest X-ray. So, and it's a good study. So I guess final read is adequately good study, left effusion, cardiomegaly, and just diffuse nodular opacities.
Oh,
which is certainly suspicious for some sort of infectious process.
Like, I like how you did like a final read there, just like in the radiology report. That was so perfect.
Correlate clinically.
Yeah, correlate clinically. Yeah, I have the same thoughts. Just to give the listeners like another visual, these nodular lesions, they look, if I had to estimate, like they'd be almost like 1 centimeter in size, or like all of them. Mm-hmm. And if I had to guess, if we did like a CT scan of these axial slice, go all the way down, they look like they would be like randomly distributed. I know you can't say that with a chest X-ray, but they're so numerous and so all over the lobes that I would make a guess that they're randomly distributed. And if we're going to play this game of, is this related to an underlying infection, which is the game we're going to play, since we want to make sure we can treat an infection and we're not missing it. What can spread hematogenously throughout the lungs? These are things that can originate from endocarditis if there's something living on the valves and being thrown everywhere. There are some bugs that just do this without endocarditis, like anaerobic infections, Fusobacterium can do this. But then, you have things like tuberculosis, and Alec shared with us this patient was in Mexico, I believe, 3 years ago. And if Mike is telling me he sees an enlarged cardiac silhouette, which on a chest X-ray, just to be clear for the listeners, an enlarged cardiac silhouette doesn't necessarily mean that the patient either has pericardial effusion or cardiomegaly. You can't really say unless if you see what I think is called the Oreo cookie sign, which is like 3 different densities that kind of suggest a pericardial effusion on a chest X-ray. But I'm going to make the bet, since this patient's BNP was stone cold normal, and you said no peripheral edema, Alec, right? Not yet. Yeah. So, I mean, no peripheral edema, negative BNP with a heart this big, that just doesn't add up. Like any sort of atrial stretch is a very sensitive marker, the BNP blood test. So the fact that that's stone cold normal, I would bet that enlarged cardiac silhouette is from a pericardial effusion. So now we're invoking serositis of the pericardium, something spreading hematogenously throughout the lungs. And I mean, the first thing that comes to mind to me is TB. Last observation, Alec gave us an alkaline phosphatase that was a little bit elevated, in a young patient in the absence of bone disease and osteomalacia and an undetectable vitamin D. We have to explain that. And the fact that there isn't sort of any abdominal pain syndrome suggesting local obstruction of big hepatobiliary ducts. Usually when I see an alkaline phosphatase that's like moderately high like that, and then you don't see an accompanying bilirubin. I don't even know where I learned this, Pearl, but this has just been passed along from so many morning reports. That is a signal for often infiltrative diseases where there's just local irritation of the biliary endothelium that releases alkaline phosphatase, but not so much so that there's frank obstruction of bile leading to a hyperbilirubinemia. So I think putting it all together, it's looking like we have something spreading hematogenously, perhaps infiltrating the pericardium, causing an infusion, and perhaps living inside of the liver. And suddenly this patient's in a TB room for isolation in Alex Hospital. But Mike, any other thoughts before we move on? Is there anything else you want to do other than a TB room?
A TB room is a good start. He's young, right? But he is tachycardic, right? So his body's feeling this. I think you sort of have to start this guy on broad spectrum antibiotics and consider the fact that your normal, vancomycin or not, probably won't, maybe not covering what could be here. But I do think, right, the common things are common. And so you probably would start this person on at least a day while you're kind of the dust settles. It would be really good. This is a guy where, if he is, I forget, is he making sputum? Is this a dry cough?
It's a dry cough.
Okay. All right. Yeah. So, obviously if he was really kind of bringing stuff up, you'd send that off because it would be probably valuable here, and you would send off AFB as well as everything else. But no, I think I agree that there seems to be something that is systemic and inflammatory, and infection probably more likely than malignancy by a lot here. So, and again, like you said, TB is a very common cause not in the United States, but in the outside of the United States, right? Of pericardial effusions, pleural effusions, and those lung findings. And certainly you can get disease in the liver as well. But yeah, I'm interested to see what happens next. I don't think I have a lot else to add outside of that.
And Alec nicely, he just put up a slide to go over the data again. I'll just be super brief because I know we have a lot of aliquots to go through. But just something else that we'll have to tie in later is probably the low hemoglobin with a high MCV. If this is a fairly healthy guy, no reason to have B12 deficiency other than pernicious anemia, which we've talked about before. Maybe he's hemolyzing here. This is some signal for hemolysis where reticulocytosis can cause the MCV to be up. So I think sending hemolysis labs for that anemia just to stratify it a little bit further would be helpful. And then I think we should just say that platelet counts in a patient with inflammation and signs of an underlying infection, I think suggests that this patient has probably been having a disease process longer than he has been experiencing it himself in terms of his symptoms, just because it takes a while for patients to generate secondary thrombocytosis related to a chronic inflammatory process. So I think that whatever is going on has probably been going on for a while longer. But Alec, what do you do next?
Awesome thoughts, guys. So I'll give you some more information here. And then just for the chest X-ray, they read it as multifocal pneumonia with a left-sided effusion. And they said they couldn't really differentiate whether this was a cardiomegaly, a pericardial effusion, or if there was something posterior going on in the lungs or the mediastinum. So they had recommended additional imaging, which we'll get to later on. So for some additional information, HIV screening was negative. His hepatitis panel was also negative. Blood cultures after, 48 hours, no growth to date. Sputum, we were able to get eventually after he expectorated a little bit, didn't have any growth. All of his other STI screening was negative. We did do a quantiferon gold as well, which was negative. In regards to his anemia studies, his haptoglobin was 323, which was high. His vitamin B12 was 210, which was normal in our lab is about 300. His ferritin was 1500, normal being less than sort of 250 for our lab. The iron and TIBC were both low, and his TSAT was 15%. His LDH was 575, upper limit of normal being 271. His uric acid was normal. Then I can give you the CT scan as well. Still images here. That's that one and this one here. Then I have one more here. And if you want as well, I have a video I can play for you, which we can describe to the listeners afterwards.
Could you play it one more time, Alec, from the top?
Yep, it's gonna go up now in the long view. Yep.
Okay. Is that like large adenopathy on the left side, Mike? Is that what we're seeing?
I can't tell if that is like mediastinal bulging out or if it's part of the lung parenchyma.
So I can give you the representative cuts which I have here. So this is part of the sort of the upper portion of the lung here before the carina. And then this is here where you would expect the right ventricle to be, but just a little bit above that. And that green arrow that you'd seen on the radiology was for the thing in the right, in the left hemithorax there. And so just another representative example of that. I will get your reflections on that, and then I can give you the formal CT read.
Oh, I don't know what to make of that kind of. I don't know if I'm seeing a mass lesion there, Mike. I'm not sure what to make of that. I would have to talk to radiology. But I guess the takeaway is, I mean, we called it an enlarged cardiac silhouette, and it does not seem that is the heart. So the principle ended up playing out where if you see an enlarged cardiac silhouette on a chest X-ray, it doesn't tell you what it is. I've certainly never seen it something kind of like external from the heart completely. So yeah, I don't know if that's like primary tumor, like a huge abscess. No idea, but it seems like we're probably headed toward getting some tissue from that area to try and figure out what exactly that thing is. Alec, how did they read this?
Yeah, thanks for playing along, guys. So the CT read was this was a 9 by 10 by 4 heterogeneous, well-circumscribed mass that may originate from the anterior mediastinum. And they read this as innumerable other interpulmonary masses. And that main mass was continuous with the mediastinum and extended down to the lower paraesophageal region. There was no pulmonary embolus. The airways were patent. There was a moderate left pleural effusion. And that conglomerate mass, as we had discussed before, extended to the left hilum and the paraesophageal region. There was a little bit of left to right shift, and some of the left anterior pulmonary arteries were a little bit compressed, but there wasn't any suspicious osseous lesions. And, for some additional history, I went back and spoke to him after I saw this. And started thinking about mediastinal masses and whatnot. So I asked him about any testicular pain. He wasn't having any. He had no swelling, penile discharge, or any other issues. There wasn't any inguinal lymphadenopathy on exam. No testicular masses that I noticed. And we ultimately got a testicular ultrasound that didn't really show anything except for a small left varicocele. And, I'll stop there and get reflections, and I can give you some more information after that.
I feel like the findings shift the differential towards something malignant rather than something infectious, just right, a mass, and can you have something on in your lung that looks like a mass on CT for sure, but usually there's some sort of cavitation to it or different sort of, it's heterogeneous, which I guess this thing sort of is, but I think I'm much more worried again about, I think I'm most worried about lymphoma, I guess. But I guess that's where my mind goes first. You already mentioned sort of seems to be relatively ruled out testicular cancer. And I mean, I think the thing that I would probably want next is tissue, like Andrew mentioned. But while we're doing that, I'd probably scan the abdomen, pelvis, and see if there's what's down there. Because I think, especially since there's masses in the lungs as well, in addition to this mass in the mediastinum. I don't know, Andrew, what are your thoughts?
Yeah, I agree with you. We already talked about how there is some signal in the liver. I mean, we still have an infiltrative signal in the liver. It's probably related to what's going on in the lungs too. So yeah, I agree with the abdominal imaging just to see if there's anything that looks primary there. But I think you're just interested in comments on like why we're making this massive pivot, because the story was pneumonia, the first 3 aliquots, but then we saw the chest CT, and I think, to say out loud, what we're doing is, and we'll have the image on the website, the nodular lesions are very like smoothly circumscribed. They look almost like cannonball like, which is I think why Alec was telling us they looked around the scrotum and did an ultrasound around there to look for tumor, because testicular cancer, one of those subtypes, can look like that. And, I'm not very comfortable in the mediastinal space. Certainly we need a biopsy of one of these lesions, but I couldn't give you an extensive DDX for if this is where it's coming from in the mediastinum, what that's going to be. My illness script for Hodgkin lymphoma, which is like a fairly common disease in this age bracket, certainly does include very large mediastinal masses, but the finding of these like parenchymal infiltrates, not so sure that that's on there. I'd have to look into that. I've seen some pretty gnarly metastatic bone lesions from Hodgkin's that are quite large, but parenchymal infiltration I have not seen. If there was any sort of comment on the CT of anything suggestive of lymphatic spread and like perilymphatic hyperdensities on the chest CT, maybe that would point us in that direction. If all those nodules were not randomly distributed, as I had initially said, but instead they are following the lymphatics, that may actually point us more toward a lymphoproliferative process like Hodgkin disease. But I think this is all conjecture when we're going to end up getting tissue here. And those are my final thoughts. I'm very curious. How many more aliquots do we have, Alec? Because you said 9. I don't even know. My brain is just confused now.
Yeah, just I think about 3 more.
3 more?
So right, I'll give you some more, laboratory information. We'll get to the biopsy and then some additional clinical course. Mike wanted the CT abdomen pelvis, so we did that. And that demonstrated mild hepatomegaly with multiple hepatic metastases, the largest of which was about 4 centimeters. No splenomegaly, no lymphadenopathy or other findings in the abdomen, however. And then with the tachycardia and the mediastinal mass, we got some thyroid studies that showed that a TSH was undetectable. His free T4 was 2, upper limit of normal being 1.4 for our lab. And his total T3 was 209, with the upper limit of normal being 178 for our lab. So we got thyroglobulin, thyroid stimulating, thyroid peroxidase, and thyrotropin receptor antibodies, all of which were negative. And his ultrasound of the thyroid was also normal. And then we did some additional autoimmune testing, and just the following studies that I'll reveal to you were all negative. So he didn't have diabetes, NS-PEP, serum free light chains, all normal, ANA with subserologies, and then ANCA testing, Andrew's favorite, were all negative, in addition to the complement and cryoglobulins. And I will stop here, and then I'll give you one more lab test before going on.
Alec is saying that was my favorite because one of my first CP solvers presentations was cavitary lung disease that looked just like cancer, and it ended up being a GPA. Thanks, Alec. That's a lot of good information there. I don't know how much signal there is in this in these thyroid tests, Mike. I wasn't super overwhelmed with kind of how elevated the T4 and the T3 were with the suppressed TSH. I know there's this phenomenon where some tumors can secrete beta HCG, and that's kind of acts like TSH because it looks like TSH. It can cause the thyroid to release thyroid hormone, and that can produce thyrotoxicosis. And of course, if there's something being secreted by a tumor that looks like TSH, your body will naturally suppress its own TSH, which is what we're seeing here. So I don't know if that's what's being given here. My understanding of that would be I've seen that phenomenon described in females with ovarian tumors. I don't know if men have a version of that, but we've already exonerated a primary testicular mass. Is it possible that there's something that was very microscopic there and it just took off? Maybe that's why it's a diagnostic atypia episode. I'm not sure, but yeah, I don't really know what to, because I feel like the one abnormal we were given there that at least stuck out to me were those thyroid studies, but I don't know. What do you think?
I mean, it's always like, thyroid studies are notoriously hard to interpret in someone who's acutely ill. So I'll just say that to start. I'm trying to think of a way that you could have sort of like thyroid tissue in the mediastinum, going back to embryology, but I don't know that you can have tissue that far down. I could be wrong about that. And then, could that tissue have transformed into thyroid cancer? But again, that's not really, doesn't fit this age group. I feel like it might be a red herring. The thyroid studies being implemented, influenced by like a paraneoplastic syndrome is interesting. But I don't know if I can generate a great differential based on that. I guess one thing that I will say is that the liver lesions are read as Mets, and lymphoproliferative, I think, is still what I'm thinking overall. But if it's not lymphoproliferative, is there something in the GI tract that we're not thinking of? But I just don't know how you get an anterior mediastinal mass with that. So I don't know that I'm anywhere different from where I was. I think I'm still worried about lymphoproliferative lymphoma, I think being the most likely here. And it's in the liver like it is in other places. But yeah, I'm interested to see if the thyroid studies are a clue here, because I don't know how it would fit in.
Awesome. Amazing reflections, guys. So Andrew, you really were right on top of it. So we got a serum beta HCG, which was 501,665, with normal being less than 3. So very, very, very elevated. So we ended up getting a biopsy of the mediastinal mass, which had a bunch of immunohistochemical stains, which I'll spare you, but they thought it was consistent with a germ cell tumor, specifically choriocarcinoma, that was extratesticular, so actually began in the mediastinum. So he was started on VIP, which is vinblastine, ifosfamide, and cisplatin on day 5 of admission after we got the results. And then on day 7, so prior to his 3rd dose of the chemotherapy, he developed rapidly progressive dyspnea, going from room air to a non-rebreather in a few hours. And he got another chest x-ray, which showed this.
The case doesn't end.
It doesn't end yet.
Oh my goodness. Oh, what? All right, Mike, I defer to you again. Our pulmonologist.
So I guess the initial impression is worse. Yeah, wow. So he has, I believe, a very large effusion on the left, or maybe this is the mass superimposed. That's sort of where it was. But then, I mean, there's more white than black in the lung fields. There's just sort of innumerable lesions throughout all the lung fields, really high density of these lesions. It's pretty impressive. I mean, it would be a very severe atypical multifocal pneumonia if that's what this was. So I guess that's how it would probably be read in isolation. But obviously, this is within the context of this case.
Yeah, I feel like, I mean, the nodules make the interpretation of this a little challenging, but if I didn't know about it, I feel like this looks almost like an ARDS type of chest x-ray with just how many alveolar infiltrates there are now and kind of like how dense they are. I don't know if this is an expected phenomenon with this germ cell tumor to the chemotherapy. If it's like in terms of like a kind of like this means that the tumor's responding and this is like a good thing, like, and this patient's going to eventually kind of like get over this hump, may need to be on the ventilator for a little bit, or is this not a sign that it's like sensitive to it, but is this like a pneumonitis type of reaction to one of these drugs? There's a website called Pneumotox. I can't remember if it's still around. I haven't pulled it up in a while, but there are resources online where you can plug in chemotherapy agents and any agents to see what the risk of pneumonitis is and other like parenchymal lung diseases related to drug administration. So I guess I'd be pulling that up to see that. And I guess management wise, we'd probably want to keep this patient on the drier side at this point, since it's likely one of these phenomena. So probably just give some empiric diuretic, and I wouldn't be surprised just based off how bad this chest x-ray looks if they're going to need the ventilator for a little bit just while things kind of cool off. But Alec, what happened?
Yeah, so X-ray just read as diffuse pulmonary opacity is concern for ARDS. So unfortunately, he continued to get worse with accessory muscle use and refractory hypoxemia, and he ended up getting intubated. And he was noticed to have diffuse jerking, which was concerning for a seizure. So there was a CBC done, which showed a drop in his hemoglobin from 8 from that morning to 6 at the time of the repeat. And a bronchoscopy was done with 500 WBCs, of which 60% were macrophages, and 75,000 RBCs with serial washing showing progressive redness. His coags were normal. His fibrinogen was 600. His BNP still was normal. And for the possible seizures, he had a brain MRI done, which showed tiny scattered foci of acute peripheral ischemia, mainly in the supratentorial brain, with potentially consistent with embolic infarcts. And then he had a minimally enhancing hemorrhagic lesion in the right inferior parietal lobule without significant regional edema. And that's where I'll leave you. And the next aliquot will reveal the final diagnosis.
Whoa. I don't know much about the brain stuff. I'll try and save that for Mike, but we're not neurologists, so I'm not sure how much progress we're able to make on that stuff. I think what we're hearing, though, was some evidence of diffuse alveolar hemorrhage with RBCs. Did you say serial lavages, Alec? Is that? Yeah. So diffuse alveolar hemorrhage is kind of what we're seeing. You can see that as a result of coagulopathy. It sounds like that's not what we are seeing in the lab. So a patient is not supracoagulopathic. It's not like a bleeding tendency. You can see in capillaritis, which of course we already got the autoimmune workup, and this patient doesn't have any reason to kind of develop that acutely. And I think just diffuse alveolar damage can lead to diffuse bleeding like this. So I'm thinking that they had some sort of reaction to the drugs, either that be like inherently from the drugs or like this tumor responsiveness. I have no idea, but how to tie that into the brain, I'm not sure. So final thoughts, Mike? I'm just curious to learn.
Yeah, just for the lungs, I agree with what you said in terms of like, I feel like it's either the chemo or it's the tumor itself. Like the burden of disease was just so high that, the treatment of it and the lysis of that, of those cells, it's just kind of like an overwhelming amount of destruction that, the lungs just, there was a lot of tumor in them. I mean, could you have tiny little lesions of the malignancy in the brain, and then it bled when you treated it. But it doesn't sound like that. It sounds like these are really small and almost kind of like a shower of emboli.
Yeah, while you're thinking, Mike, just a thought that came to mind, because it sounds like there weren't any large brain lesions, and if anything, what we saw was pretty small. There is this phenomenon. I don't know if if this particular term applies to cancer, but like non-bacterial thrombotic endocarditis, I want to say it is, but you can see basically thromboembolic phenomenon that you would routinely see in endocarditis, but from non-infectious causes, and you can have like sterile clots or cancer. Both don't cite me on that, but causing the same exact consequences. So maybe there's something living on the valve that just happened to go to the brain, just because we know it's everywhere, and just it was poor timing. Maybe that's what happened in terms of the brain story. But I think I'd put my money on that, just given there's no like large brain lesion, just because everything else, everywhere else, the lesions are really, really big that we're seeing, and that's not what we're seeing in the brain. So I'm not sure if an echo will show some sort of like small vegetation, but I think given how multifocal it is, and this red is kind of like I forget how exactly it was read, but it was very suggestive of some sort of like proximal showering, as you said, Mike. So I think we can like presume probably that there's going to be something on the heart.
Yeah. And we know that like autoimmune diseases can cause like a, culture negative endocarditis. So I wonder if that's true for this specific kind of malignancy, like you said.
Yeah, amazing thoughts, guys. This was a really difficult case that I encountered. And so essentially the echo didn't reveal anything. And we ended up getting some subsequent MRI imaging that showed that probably he did have metastatic lesions, that they just were really small at the time and just got a little bit bigger with time. So what we thought the final diagnosis is that he had metastatic choriocarcinoma causing beta-HCG-induced hyperthyroidism, which was complicated by something called choriocarcinoma syndrome, which is a very rare complication of germ cell tumors, particularly choriocarcinoma, because it's a very vascular tumor, and it can either all the lesions at one time can either bleed spontaneously or be triggered to bleed. So what we felt had happened is basically after he got the chemo, all of these lesions bled spontaneously. So he got DAH related to that, and then the brain mets also bled, which led to seizures. And so, that's what we thought what was going on. And I'm glad to say that fortunately the patient survived, and he was able to, because the mortality associated with this, it's very rare, but can be very high. And he was able to tolerate another 2 cycles of chemo, and he's still, fighting this, and he's doing well.
Wow. Yeah, amazing outcome, Alec. Really happy to hear that for the patient. Was not expecting to see choriocarcinoma from the aliquot of cough and can't lie flat. That is something else. What a journey.
And I think that it's a good reminder of like when the pretest probability breaks down a little bit, right? Because like 30-year-old with inflammatory syndrome is like infection is going to be much more common. The same syndrome in someone who's 80, right? Like if it was the same history, but the person was 80 years old, then, malignancy is certainly equally as common, if not even sometimes more so. So, and then even then moving into the malignancy territory, thinking of basically just lymphoma and not really thinking about, I don't know that I ever would have gotten to this diagnosis, but I just think it's this, bent the script in that, like, we were so focused on infection, and I think most people would be.
Yeah. Well, what else did you extract from this, Alec? I'm sure you have a lot of insight.
Yeah, I think you guys really went on an authentic diagnostic journey. So I sort of have different phases throughout the night with this patient alone, and then throughout the days as I was reviewing his chart. But I certainly started with infection. And then Andrew, sort of astutely noted that the time course just didn't smell right. Tempo is queen and everything in medicine. And it was just a little too long, and he was just a little too sick, and without any real clear risk factors. And then I think one of the first clues was the X-ray was just very weird. And you had already mentioned the idea of cannonball earlier on. And when I saw that, I was like, was it like that or not? And, Mikey noted that we had to treat him with antibiotics regardless. And certainly we were doing that up front. And that was our primary concern initially. But because of the sort of oddness, and then there was that potential cardiomegaly versus a mediastinal mass, we went right to the CT. So probably, 6 hours later, as I had the CT. And so I was able to look at that, and it looked even more like cannonball mets. There was no clear parenchymal finding that was super suggestive of a typical, bacterial or, even like atypical pneumonia per se. So I think, we shifted from primarily infectious to malignant around that time with the mediastinal mass plus evidence of disseminated disease elsewhere. And it's pretty common in the hospital that, one of the first tests we send for a young person with tachycardia is thyroid studies. And I actually got those back around the same time. And I just had the unfortunate privilege in the past of actually seeing a patient with beta HCG induced hyperthyroidism in the past. So it triggered me to think about this with the way that the lesions looked. And so I actually sent the beta HCG that night as well. And so we were actually able to get the beta HCG back before he got the biopsy, which was even more of a clue that this was probably malignant. But it was just such an amazing journey from infectious to malignant. And then the choriocarcinoma syndrome isn't something I had ever heard about, and is very rare. But it's something that I thought was really interesting about this case. And it was just a lot of learning that I had distracted from it. And it was, just in one night, I went and saw him, about 3 times doing different parts of the exam. I didn't even thought about doing a testicular exam initially. And, I had to go back and do that. And I know this was a challenging case, and I really think you guys did a good job sort of being authentic with how you would be tackling it and leaning into consultants and the radiologists and into tissue, because that's what I was doing too. And I hope you enjoyed discussing it. And
Yeah, amazing reflections, Alec. I guess my final thought before I pass it on to Mike is I'm curious people's threshold for when they would send thyroid studies for a patient with sinus tachycardia. I'm just putting myself in your shoes and walk in a room, a guy who's been having trouble walking around for a while, dyspneic on exertion. He's having some pleuritic discomforts. I think I totally, with a heart rate, I think you said in the 120s when he came in. In terms of my kind of barometer for how out of proportion I would say that patient's heart rate is,
I probably wouldn't have sent them if I'm being totally honest. I do feel like I've been burned enough on thyroid disease, missing it, that there's definitely a reality where I may think of sending it, because I feel like I do send it probably more than I should in many cases. But I think the fact that I was so anchored on infection it would not have been on my first 24 hours of workup, I think. And so I would have missed that would end up being a clue.
Yeah, I guess if it looked more like sick euthyroid syndrome, I even forget the name, the phenomenon where the tests are slightly deranged in many different directions because people are sick. It's a little bit more muddy, but this was a pretty clear cut case. So I don't know. I guess in terms of management reasoning, thyroid studies could be thought of as just low hanging fruit, blood tests, very very specific if you see it in a particular pattern in the right context, but of course very non-specific if the findings just aren't really adding up and they look more like sick thyroid syndrome and the story just doesn't add up. But yeah, I think I'm going to be sending more thyroid tests after this. Thanks, Alec, for coming again. Really appreciate you being our first guest on the show. Learned a lot from this, and we'll have to do some reading after this for sure.
Alec, great to meet you. Thanks so much for being on the show. That was fantastic.
Yeah, thanks guys for having me. I appreciate it. And keep up the great work.
This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.